We are going to be focusing on the topic of GI health and nutrition. And so we are going to be joined by Rachel Schrader, who is PPMD's Vice President of Clinical Care and Education. And joining Rachel on this panel, we have Kindon Fawcett from Arkansas Children's Hospital. We have Kent Williams from Nationwide Children's Hospital and Kiara Bergen from Virginia Commonwealth University. So with that, Rachel, I'm going to hand this discussion over to you.
Great. Thanks so much, Eric and Ryan. I'm really excited. We have a wonderful group of speakers with us this evening to talk about the ins and outs of GI health. Really great panel, and I think that you're going to learn a lot from each of them. Please feel free to submit any questions that you have for the speakers throughout the course of the presentation, and we'll get through as many of those questions at the end as we can. So I think with that, we'll go ahead and jump right in. I'm going to hand it over to Dr. Kindon Fawcett of Arkansas Children's Hospital. Dr. Fawcett, take it away.
All right, thank you so much. It's so nice to be here today. So I'm going to talk a little bit today about, I'm trying to get my slides to, okay, there we go. Sorry about that. I'm going to talk a little bit today about nutrition and what we can do as providers and as family members for our boys and possibly girls if you have one. So just to bring a little bit to the table, I kind of have a dual role when it comes to this disease. I am a practitioner and I do research in nutrition and neuromuscular diseases, but I also have an 11-year-old son that has Duchenne muscular dystrophy. So I like to think that we try to practice what we preach. So on that, I will ask for my next slide, please. So we kind of have two different ways that we can look at it. You know, we can look at it from the clinician standpoint and we can look at it from the family standpoint. So what we can do when we go into an appointment is to really try to focus on what we're doing for our boys on the prevention side. So we're going to talk about three things today: weight management and health, the dietitian role, and then also the family role. So I'll take that next slide, please. Thank you. Okay, so what can we do and where do we go to find help? So with our weight management and health, we really need to know how many calories our boys need. So a great way to start out with that is to, number one, if your provider hasn't helped you find a dietitian, go ahead and advocate for yourself and ask to see a dietitian. So with that, they're going to talk to you a little bit about what our boys need caloric intake wise. And one of the best ways we can do that is with the Mifflin-St. Jeor equation, and that's going to give us our basal metabolic rate, which tells us what we need to just live and breathe. So that's without exercising, that's without, walking to your car or doing those activities of daily living. So that's a good way to start out. So we have a baseline of what our boys actually need, because an 11-year-old that is non-ambulatory in a wheelchair is going to have a very different BMR than a very typical 11-year-old boy that plays soccer. And then secondly, we're going to look at choosing the right foods and portion size. So a lot of times we have so many questions about, well, what kind of foods do my boys need to be eating? Do they need protein every meal, et cetera, et cetera. So some things that we're really going to try to focus on are choosing foods with a high satiety factor. And that just means foods that keep us feeling full longer. So think about the difference of when you eat a Snickers bar and it feels really good for a few minutes and you feel good and you've got that really good energy, and then you kind of have that crash, which, people call it a sugar crash or whatever you want to call it. Versus when you eat a whole grain piece of bread with some turkey and some cheese, a sandwich that keeps you feeling full longer. So that's going to have a higher satiety factor. So things that keep us feeling full are whole grains, vegetables with fiber, proteins, and, foods that keep our blood sugar at a stable level. So fruits and vegetables, we say, kind of when we're looking at the My Plate, fill half your plate with vegetables, and then snacks, use fruits and vegetables as snacks, and try to stay away from those processed, bags, boxes, things like that. So also, I always like to add when eating your fruits and vegetables to eat the peel, unless it's, a banana or something like that. And then, like I said, a protein at every meal and snack, just because that usually gives us some good energy and it helps us stay feeling full longer. and then limit or eliminate those sugared beverages. I'm not going to say that you can never eat a candy bar again, or you can never have a piece of cake or anything like that. But if you can try to limit those, and then also limit those sugared beverages, and then drink water. This will help so much in digestion and also help you feel fuller longer. So I'll take that next slide, please. So when to ask for help, we are really trying to focus, especially at Arkansas Children's Hospital, about getting us to a point before we need it. So on the prevention side, so trying to get our families in to see a dietitian before their sons have gained, 30 pounds since their last visit. So we always want to say, see a dietitian at the onset of steroids. And then we are really trying to change our standard of care and practice at Arkansas Children's to see a dietitian at those multidisciplinary visits, which for us is every 6 months. And then additionally, if that growth curve changes. So we see a lot with DMD that our boys' growth changes are higher. And then with our Becker boys, they tend to be on the lower end, a little smaller in stature. And then also other things to consider. So glucose metabolism, mobility issues. And this is one thing that maybe you don't think of until you're in that situation. When your boys stop walking, then their caloric intake changes. And then respiratory and cardiology, that's a hard one for me. Cardio functions. And then also looking at our undernutrition and our muscle function. So just like anything, you have to have enough food and good food and energy to keep you feeling healthy. And then other things that we'll talk about, GI complications, constipation, and fiber and water can really help those. Chewing and swallowing difficulties. And then some of the other things that we want to consider are calcium and vitamin D deficiencies. And one of the things that we had to look at when we were starting to look at some of the data of our boys, we were prescribing vitamin D to these boys. But if you don't have calcium with your vitamin D, sometimes you don't absorb it as well. And then we also want to look at those factors that affect osteoporosis and osteopenia. So making sure our boys are still getting some exercise and some weight bearing mobility. So I'll take the next slide, please. And then finally, just really talking about it as a family role. So I'm never going to tell someone that they need to change their eating habits, but for their boys, but nobody else in the family has to. So it's not like you can sit down to dinner and be like, okay, Timmy gets a salad with some grilled chicken and everybody else gets pizza. That's not the way it works. If a family wants to do this, we have to make it as normalized and as for the whole family. So it's just everybody does it. It's not we keep somebody kind of out of the loop. So like I said, we change the whole family's eating habits, and then we're going to unlearn those healthy coping and eating practices. So we did a research study and we found a lot of parents tend to be emotional eaters, or they give their boys maybe food to kind of cope with some of the other things that they're not getting. And I will be very honest, we've done that with our kiddos. Hey, I know everybody else is doing this. Hey, do you just want to watch a movie and eat some popcorn and have some, candy and stuff? So trying to really focus on really thinking about food as just energy sources, not as a reward, not as a punishment, not as good or bad. And then also just stop that emotional eating. And we all do it, oh, I'm sad, I'm going to do this, or I'm going to do that. And then also incorporate the participation and learning about nutrition. So when you're in the kitchen, bring your boys in, bring your family and talk about, hey, we're having this for dinner. And let me tell you what nutrients a carrot has. I know my son's name is Tyler, and I know he really enjoys talking about that. And he's actually getting very good at telling us all when we're not doing a very good job eating healthy. He's like, now, I don't think you're supposed to be eating that, Mom. I think you had one of those yesterday. So he's kind of become the nutrition police in our house. And then also just being an advocate for your kiddo and your family. If if you want to know more about nutrition, you can always ask to see a dietitian. And I think that that's something that maybe is a little bit unfamiliar when families come into clinic and into these multidisciplinary visits, because they don't know all of the things that are out there for them. So just knowing that it's okay to ask for things, or if you're unclear or you need some more guidance, we have plenty of it. And one of those other things with that is encouraging physical activity. I was just in a meeting with our department chief of neurology, and we were talking about how those micro tears are actually okay. For so long, we said, don't let these boys exercise, don't let these boys do anything. But now we're like, okay, it's kind of use it or lose it, use it while you can, because at some point you might not be able to. So physical activity is okay. So next slide, please. So with this is just a fun kind of little pictures of all of our family doing all kinds of stuff. So we have Tyler doing everything from basketball that we had at our youth center to a color run. That's me with the color shirt on, pregnant with our youngest. And then we went to an animal farm, and Tyler does everything with us that anybody would. It's just sometimes you have to make a few adjustments. So that was just kind of showing you guys that we get it. So if there's any questions, you can always ask me about it. Next slide, please. So nutrition is one of the most important things that you can do for your son, or if you have a daughter with one of these conditions. And it's mostly just educating yourself and not being afraid to ask questions. Next slide. Questions.
Great. Thank you so much, Kendan. We'll go ahead and save the questions for the end. So a reminder, everybody that's tuning in, go ahead, submit those questions, and we'll have great conversation. Thank you so much for those amazing points, Kendan. I think that, it's just such a great reminder that a dietitian, having that nutrition person on your care team, part of that multidisciplinary team, is just so important when it comes to really comprehensive and well-rounded care. So let's continue the conversation. Next up, we have Dr. Kent Williams of Nationwide Children's Hospital.
Hey, thanks, Rachel. So I'm a GI doctor. And so a lot of people through the years kind of got to know me as the poop doctor or the poop king, because I talk a lot of crap, but it's one of the things that really does help improve the quality of life of our young men. So next slide, please. So giving me only 10 minutes is very limiting to me. As many of you also probably know, as I like to talk a fair amount. So it's hard for me even to introduce myself in 10 minutes, more or less try to talk about GI issues in 10 minutes. But given that task, trying to pick the two topics that I feel like are the most important and then help to improve the quality of life best for a young man with Duchenne's would be bowel management and the timing of a G-tube. Next slide, please. So bowel management. I don't want to talk about treating constipation as much as I want to talk about bowel management. But constipation is very, very common in patients with Duchenne's. And it's not just common at the end of the life, but it's throughout the whole life. There was a study done by my colleagues at Cincinnati Children's where they looked at about 120 young men with Duchenne's, and they applied what we call the Rome criteria for constipation. Just randomly picked them. And what they found is that at least half of them met the criteria for constipation. Now, what was really interesting was that the constipation did not go up with age. It was not associated with age. It happened throughout the whole spectrum of life. And I think one of the big reasons is because a lot of the kids, when they're young with the Duchenne's, they actually have a lot of the behavioral traits that go along with kids that have significant constipation, anxiety, OCD, autism, and different types of behavioral issues that predispose you to having constipation. Now, diet plays a role in it, and so having a good diet can help, but a lot of issues are more on having behavioral issues, sensory issues, and then later in life, trying to regulate your life so you don't have to worry about having bowel movements. It can get you in a lot of trouble. So it happens later. But of those half that they found that had met the criteria, about half of them had never been told that they had constipation. They were completely clueless about it, and it was just completely unrecognized, not only by them, but by their practitioners also. And you ask, how can that happen? If you don't, most people think of constipation being you don't poop. Well, let me show you an x-ray of a young man who pooped at least 2 or 3 times a day. Next slide. Now, I don't think you even have to be a doctor to realize that that thing in the middle is not normal and should not be there. And that thing in the middle is a big, large fecal impaction. That is all stool. Goes from the pelvis all the way up, pushing into the diaphragm, which makes it difficult for this young man to breathe. And as you can imagine, also makes it difficult to eat. When I first met this young man, he was losing weight also. So, but no one had ever diagnosed him with constipation. In fact, they thought he had problems with diarrhea, and that's why they were sending him to me, because he was having 3 to 4 loose stools a day, many of them out of his control. And they were worried that he was having like some kind of disease or problem going on in his colon, but it turns out he was severely constipated. So constipation is not just whether you go every day. In fact, there's a whole list of criteria. Next. Now, I don't want people to try to memorize every criteria. I'm going to give you that little cheat sheet that I use in the next one, but I'm just using this slide to basically demonstrate there's at least 7 criteria, 2 of which you have to be able to be diagnosed with constipation. And frequency is only 1 of the 7. Basically, you have 2 or fewer defecations per week. That's 1 of 2 criteria you've met for having constipation. But basically, if you're withholding stools, have large stools, having stool accidents, those are all criteria also. In fact, through my years of doing this with children, not only in Duchenne's, but autism and with other developmental issues, I've come up with 3 questions of my own that I always ask, seem to be pretty good in my clinic for trying to determine if someone's at risk for having constipation. Next slide. The first one, does your child have holy cow bowel movements? Now, if your child has constipation, significant constipation, you already know what I'm talking about. And usually a lot of times when I ask this question, parents go, yeah, then I know they already have constipation. The ones that have severe constipation are like, holy cow, what do you mean? What I mean by a holy cow bowel movement is your kid has a bowel movement and you go, holy cow. And you're either taking pictures to show it to somebody, or you're calling your wife or husband or someone in and look at it. I can't believe this came out of him. It's like huge. So that's that very large stool. That study that I was talking about earlier, that was the most sensitive for being able to determine whether someone was constipated, is having very large stools. Stools so large, it's like they're giving birth practically. And if that's happening once, twice a week, and you have stools in between, you're constipated. The next one would be, how often do you go? And if you're say you only have 1, 2 bowel movements a week, then we'd worry about constipation also. The last one is, does your child seem to have streaks or smears? And in the younger kids, particularly ages 4 through 6, 8, this happens a lot. And the parents are like, oh, they just have a hard time wiping themselves. They just don't wipe well. Probably over half the time I find out the kids having streaks or smears in their underwear, though, it's due to constipation. Basically, the pressure builds up in the rectum and stool starts to leak out a little bit without them even knowing it. And it's not due whether they're being able to wipe or not at all. It's more due to the constipation. Next slide. So a lot of kids and young men are reluctant to be treated. They don't want to have a bowel movement. They don't want to have it when they're around other people that they don't feel comfortable with because they are dependent upon others to help them, or they don't want to have it when they're out in public. Next slide. But if you have a good bowel regimen, again, not treating constipation, but a good bowel regimen, it improves the quality of life. Basically, if you're still walking, you want to have good patterns, getting good habits so that when you get later, when you're starting to not be able to walk as well, and when you're in a wheelchair, that you control the bowel movement, not the bowel movements control you. And there are various ways of doing this that we're not trying to treat constipation. We're trying to basically keep the colon healthy and improve your quality of life. We use a lot of stimulants, where we use like a bisacodyl, a senna, like a chocolate X-lax, and we'll use large doses. And sometimes what I'll do is like, we're going to pick Sunday, Tuesday, Thursday. those are the days we're going to do a big dose to try to have a bowel movement. We'll do enemas and suppositories. People are like, oh, that's got to be terrible. But usually when I ask a young man, it's like, okay, which would you prefer? An enema or suppository and what that means, or the risk of having a bowel movement and having accidents in your pants, and they're going to pick the enema and suppositories. Same with bowel cleanouts. This is done very easily if you have a Gtube. You give large amounts once every week or 2 weeks, just to basically clean out the colon and keep it going. And then if we're really having some issues with the medications by mouth, there are surgical options that are not truly invasive, but again, people are like very reluctant to do it because it's surgery, high risk or whatever. But again, if you ask the question of what would you rather do? Would you rather be in fear of having a bowel movement in front of your family, in front of your friends? You know, because basically a surgery, putting a tube in somewhere to flush out like a cecostomy, or to have a colostomy, which is back where the poop comes into it, that you put a shirt over, no one's going to know you have that. You poop in your pants, people are going to know that you just did it, and that's a more traumatic event. So there's lots of options. Again, we're not treating constipation as much as we want to get you into good bowel reservoir to improve your quality of life. Next slide. So one way of doing that, like I said, is sometimes with a Gtube. And this is the other thing that I see a lot to be able to improve the quality of life. Next. Gtube, you're able to give medications. We can, you know, it's nasty, some of the medications you got to take for doing bowel cleanouts. We can give right a tube and we can keep a very healthy colon going. Next slide. And then the other thing is, when you get a Gtube, it's not, we're talking about taking over your eating. We're talking about trying to supplement, trying to help you from being malnourished, because as Dr. Fawcett was referring to it earlier, in the malnourished state, you're going to adversely affect, you're not going to be able to breathe. It's a lot of work to breathe. You're not going to have the energy to do it. You're going to cause damage to your heart being severely malnourished because your heart's not going to get the energy it needs to stay healthy. And then just not being able to focus and things. Next. So anytime you start having difficulty feeding yourself, whether it be with swallowing, chewing, or whether not being able to get the food there, then we need to talk about having a Gtube. Next. And if you're unable to maintain the weight, your weight starts to trend down. You need to watch your weight every 6 months at those visits. We watch every week. If you start to trend down, we really need to start talking about a Gtube. Next. And of course, anytime you're having problems swallowing, a risk for aspiration. Again, we're not talking necessarily you got to take everything by mouth, because maybe you're able to do the solid foods, but the liquids you're not able to do well. We use it as a supplement. Again, we are trying to improve your quality of life, not rob you of something. And of course, the last one, as I said earlier, is about for bowel management. Next slide. Now, again, you're still able to eat by mouth, and people always worry about the surgical risk. But once you start losing weight, once you start having complications from Duchenne's, the risk goes up. It's never really too early to start thinking about this once you start having some of these issues. And again, I can't tell you how many times people come to me afterwards and say, you know, I really don't want to do it, but man, my life is so much better since I've had this Gtube. It's so much easier. I don't have to take 2 hours trying to eat. I can keep my bowels going regularly by the medications we can give, plus the fluids and the other things. My concentration is so much better. I'm able to enjoy things more. I have so much more energy. Definitely improves the quality of life. Next. Thank you.
Wonderful. Thank you so much, Dr. Williams. I really love that last point, and I'm sure it'll come up in the conversation that Gtube can make such a significant difference in just quality of life, because you don't have to worry about shoving in those calories. You can enjoy the ones you want and, you know, supplement some extra, and it can really be a big game changer. And I know it can be a hard thing for families to think about and talk about, but that's why it's so important to have providers like you all on the care team. And I think that's actually probably a really good segue into our next speaker, who is Kira Berggren, who is a speech language pathologist from VCU. So Kira, I'm just going to go ahead and toss it right over to you.
Awesome. Thank you. That was a perfect segue from both of you, actually, Dr. Fawcett and Dr. Williams. Thank you. So yeah, I'm Kira Berggren. I'm a speech language pathologist at VCU Health. I've been working in MDA clinics in neuromuscular disease for the past 8 years, both pediatrics and adults. And I'm really passionate about the swallowing piece of things. So next slide, please. So today we'll talk a little bit about what is dysphagia, and then where does Duchenne and dysphagia kind of overlap, and then how can an SLP help? So next slide, please. And I promise I will not quiz you on well, maybe that pop quiz. But dysphagia just means basically abnormal swallowing or swallowing difficulties. And when I think of swallowing, I think of multiple things. And Dr. Williams, I really appreciate your nod to actually getting the food to the mouth as well, because that's a big piece for sure. But I look at, once we get it in the mouth, does it stay in the mouth? Are we able to move it around with our tongue in the oral preparatory phase, move it underneath the teeth, chew it up, all of that kind of stuff? And then the swallowing phases. So there's 3 phases with that. The oral phase, it's still in the mouth, and we want to move it back into the back of the throat area. Respiration and swallowing are really intimately linked too. And so when food moves back into the back of the throat area, we want to make sure, our body wants to make sure that we're not getting it into our airway. So we have to kind of protect our airway in the pharyngeal phase, or the kind of throat phase of all of this, until it moves down into the esophagus. So next slide, please. So how does Duchenne in particular affect swallowing? Some of the newer literature out there is showing that as individuals with Duchenne age, the strength of their tongue decreases. They may have some changes in the morphology of their dentition. I've had some individuals where they may have more of an overbite or an underbite as well too, so there can be some jaw issues. And the opening of the esophagus, at rest, our esophagus is normally closed up really tight so we don't get air in our tummy and burping all day long, and air goes into our lungs. But as individuals with Duchenne age, that opening may not have as much pressure, it may not be as tonic. So and then reduced hyalolaryngeal elevation, one of the mechanisms of protecting our airway has to do with our voice box area moving and kind of getting itself up and out of the way of the food passing past. And that elevation of that voice box area decreases in amplitude as individuals age. And then decreased respiratory function from a variety of factors. But as I mentioned, respiration and swallowing are really intimately related. And so if respiration function is decreasing, then it can impact that swallow piece as well too. So next slide, please. What we in patient reports from individuals with Duchenne, many of them will report what we call kind of pain while they're swallowing, or feeling as if food is stuck in the throat. I have individuals, oftentimes I see in clinic, that will tell me, there's a lot more saliva, that I have difficulty swallowing. There may be more coughing during meals or after meals. The meal times take longer. I like to always tell people kind of average in our country is about 20 minutes plus or minus for meal times. And when we start getting individuals in that 45-minute, 60-minute, hour and a half, 2 hours, I'm eating all day, that's an area where we kind of want to sit down and chat. So some individuals may have a decreased appetite, and there may be some unintentional weight loss with that. And as that respiratory function changes, we may see more respiratory infections, more frequency of choking episodes. So these are all things that we're looking at sort of clinically. And I'm really fortunate in the clinics that I'm in to have a dietitian there that I work very closely with as well too. So it's a nice kind of 1-2. Next slide, please. So how does speech pathology help with all of this? Our goal really is to work with an individual and identify what are their specific concerns. It's not really for any of us on the care team to tell you how you need to do things, but really kind of walk you through things, provide some education. There may be, we may recommend a swallow assessment. And I always like to tell people these are really not pass-fail, but really meant for us to get into the nitty gritty and see is somebody doing well, what are some areas that are of concern, and maybe are there some strategies that we can use to make people a little bit safer when they're eating. I really like to push the oral hygiene. Both the dietitians that I work with chuckle at me as I'm always asking people, how often do you brush your teeth? And even if somebody is not eating by mouth, we really want to make sure that the bacteria is not building up in the mouth and potentially being aspirated into the lungs and making us sick. So I tell people I'm not a dentist, but I do follow the ADA recommendations of brushing twice a day, cleaning between teeth. I'm not so good at limiting the sugary snacks, but we try, and visiting a dentist a couple of times a year. So next slide, please. And then really sitting down with an individual after we've done the swallow assessment, looked at specific strengths and areas of support needed, looking at what are the goals of nutrition. For most of our patients, they would tell me, young patients and older patients that I see, that eating is really a quality of life kind of activity. And do we want to include a feeding tube in there for support? And I think all of us on the panel here are on the same page of that it's a supportive tool. It doesn't mean you can't still eat by mouth, for sure. And I tell people, eat the fun stuff by mouth and do the bulk of the nutrition through the feeding tube if you choose to. I'll also chat with a person about, with taking into account those personal goals and abilities, maybe some adaptive strategies, using one-way drinking straws, or just using straws in general if it's hard to get the hand to the mouth for using a cup. Maybe using a nosy cup, maybe having better support or positioning of the body in the trunk and the arms to help support somebody if they're still self-feeding, or even just making sure they're in a good position to be safe and swallowing as best as possible. Of course, consulting with the dietitian and making sure we get good support on the nutritional side of things. And then also consulting with OT, if there's one in the multidisciplinary clinic, and certainly PT as well, for that physical support, especially if there's a lot of scoliosis or anything like that. How can we best position somebody? And then again, my bias as well to really support that oral hygiene. So next slide, please. So some kind of general tips for safe swallowing that I think about with all of my patients is making sure they're upright at 90 degrees. As I mentioned, having that trunk supported. Smaller bites and sips and single bites and sips tend to be safer, and maybe taking a bite of food and then a sip of water or some other liquid to help kind of wash down the food and moisten it a little bit. As I mentioned, straws can be good for head positioning for when we're swallowing to maximize safety with that. So next slide, please. Limiting distractions. This is a tough one. We're social creatures, especially in the evening. We want to catch up on the day, but really try to listen to your mom and not talk with food in your mouth. And think about moistening some of those drier foods. I'm with you, Dr. Fawcett, making sure that there's not one person eating one thing and everybody else is eating everything else. It doesn't have to be like that. We all eat the same things, and maybe we just have a softer meal later in the day as we're more fatigued. Taking medications, pills, vitamins in a little bit of puree, we naturally swallow stronger the thicker something is. And so that can make it a little bit safer. Or certainly if we have a feeding tube in place, that can be a really nice alternative and safer. And if you're at the table with somebody and you can see that they maybe have some additional food still in their mouth and they're getting ready to take the next bite, encouraging them to swallow one more time or maybe a couple of times to get that residue out. And next slide. I will also encourage my patients and their families to maybe have smaller, more frequent meals. So instead of trying to really get all those calories in at a single setting, breaking it up a little bit. We tell our little babies to really only go for 15, 20 minutes when feeding. And I think with neuromuscular diseases, that's actually a really good kind of goal as well to say, we don't want the muscles of speech and swallow to fatigue during the meal and put us at risk. So I'll also encourage people to what I call stage meals, or maybe if it's your birthday and you want to have steak and baked potato and a salad and something like that. Those are more complex food items. So really having them earlier in the day when we have more energy, those muscles are less fatigued. And then again, softer foods, so slow cooker items, casseroles, pressure cookers, that kind of stuff are generally going to be softer and easier. And I think we've seen some great advances over the years as well in terms of, it doesn't have to be just a puree diet. We can get really creative, and all the nutritionists I've ever worked with are just a wealth of knowledge. So please tap into them as well too. So, and really our goal for all of us here is really to manage the situation, to really make sure we're maximizing safety when you're eating, so that we're not getting stuff down the lungs and potentially causing other health concerns as well. So, and I believe that's it on my side. Next slide. just had some quick references, but I will turn it back to you guys at the studio.
Fantastic. Thank you so much, Kira. That was really helpful information. And I think that between the three of you, we've really covered the lifespan of Duchenne. And I know that problems are very different for somebody who's 4 versus somebody who's 34. And so, I think that you each really spoke to those different phases in life. So I've got a few questions that have been submitted from viewers in the audience, and I'll go ahead and just start working through some of those with you all. So I think we'll start with you, Kindan. So the question is about the role of probiotics in health and digestion. So can you talk about what that role is for probiotics, particularly how it addresses or how it can be used throughout the lifespan? So what does that look like for somebody who's maybe in childhood versus adulthood?
Absolutely. And I think, maybe Dr. Williams might want to chime in on this a little bit as well. A probiotic is definitely a good way to go, to regulate that gut health and to try to keep us as healthy and regular as possible. I always like to try to encourage people to try food items and real foods before they go just directly to a supplement or a pill or something like that. Looking at something like yogurt that would have some good probiotics to help you naturally versus, having to take a supplement. And Dr. Williams, what else would you like to add to that?
Yeah, I would say a couple of things. One is I would like to even be more natural than trying to use a supplement that people think is like trying to reset and give natural bacteria. Because the next point I'd like to say is we really don't know what natural bacteria are. I mean, we don't really have a standard of what is normal. When we do studies, and I've been involved in some studies looking at microbiome and stuff, you always have to get a control group of kids with similar behaviors and patterns, which is tough to do. So we don't really understand truly what the standards are. Now, so with that being said, I mean, I'm not opposed to using probiotics, but there's no data out there saying this probiotic is great, this probiotic works, or anything like that. If a probiotic works for you, it works for you. I'm not going to deny that at all. But there's no real strong data out there of saying what probiotics should be and what should be in them.
That's so helpful, Dr. Williams. And it's actually, I had the exact same conversation with a family this morning as we talk through, what vitamins and supplements should I give my son? What's going to help him? And we really talked about, try to have that variety in his diet, that he's getting all of those different nutrients so that you don't have to look to, additional supplementation if you can. So this next question is for Kent. So Dr. Williams, I'm an adult and I don't really like to drink because then I have to pee, and that's just complicated when I'm out and about in public. So could you speak to, is drinking all day long really that important? How does that impact my GI health?
Well, it not only impacts your GI health, because you really kind of need to have the fluids to be able to keep your stools soft enough to come out, but also going to affect your circulatory system, your kidneys, even your breathing, because if your secretions get thick, if you're dehydrated, it's going to make it difficult to breathe at times. I got to give a shout out to Dr. Shell here, who I'm sure will appreciate that I actually include something from the pulmonary system in this conversation. So drinking is important. This is where I think working with a dietitian is very important, because doctors, we're great at managing fluids through an IV. We're not so great when it comes to like what food you're eating and things like that. So I think working with a dietitian is really important in this situation. Like, what's the minimum you need? Because I think I do get it. I don't want you having to worry about going to the bathroom to urinate also and things like that. So it's very important, and I would work with a dietitian to make sure you're at least meeting the minimum requirement to keep not just your bowel regimen going healthy, but also the whole body, because it affects everything. In fact, there's lots of studies on dehydration that shows that it affects your concentration, your sleep, and other things too.
Thanks so much, Dr. Williams. I'll even add, if getting enough water in you is something that's difficult, I would even encourage our older guys to work with your PT or your OT. There are some really, really cool modifications that they can make to power chairs so that you've got easy and convenient access to stay hydrated all day long.
And
So
actually,
this next,
can I just add one more thing? This is the time, if you're having difficulty drinking, I would definitely think about a G-tube, because it's so much easier to give a bolus through a G-tube than to be worried and scared about whether you're going to choke and aspirate on it. It's very simple, and it just makes life so much easier.
Kira, do you want to add to that at all? I think that that's probably right up your alley.
It is, and I think that we can all weigh in on this one. Clearly, that hydration piece is super important for the whole system. And I would also actually put a nod out to PT and OT as well to help, because what we see a lot of times in the clinics I'm in is people self-dehydrate because they don't want to transfer, or they don't want to be a burden if they're out and about, that kind of stuff. And so there are a lot of options out there, and they can certainly help with that. But yeah, doing a swallow assessment is pretty critical too.
And I wanted to just chime in really quickly on that as well. I think, and part of what I do is the behavioral component. And I think just normalizing that this is what we do. This is how we do it. For instance, like when we travel with Tyler in the car, we have a urinal because he doesn't get out of the car every time we go. And you know what? That's just normal for us. And if somebody has something to say about it, we explain to them what's going on. But just being able to just advocate for yourself and explain, and especially when these boys are younger, helping them and teaching them how to talk to their friends or their peers about, I just do things a little differently. This is how I do it. How do you do it? Like, this is what I do. So I think just being able to kind of just normalize it, like Dr. Williams was talking about, everybody poops. Let's just talk about it.
Everybody poops. I think that's a children's book, right? No, I appreciate the candid conversation, particularly around Gtubes, because I think that topic in particular, it's just really hard to broach with families. That's a scary thing to think about if you haven't thought about it before. And it can be hard to start that conversation. But I think that, the one piece of feedback that we hear so frequently is, I wish I would have gotten my Gtube sooner, because it's just so incredibly life-changing. So this next question is for Kira, and this is a really good one, particularly for families who maybe don't have a comprehensive coordinated clinic, and that is, where does one go to find a speech-language pathologist? I haven't seen one in clinic.
That is a great question. Unfortunately, we're not in every clinic just yet. We're getting there. But I would actually recommend that you talk with the neurologist that you're working with for a referral, or even your primary care physician as well for on that. There's certainly ones in the schools, kind of a niche area. And so I'd really encourage you to turn towards the medical side of things and ask your physicians for support.
Awesome. Thanks so much, Kira. All right. So this next question is for Kindan, and it does go back to supplements, but I think that this is a good one, particularly as it relates to bone health. So what recommendations do you have for calcium and for vitamin D? What are optimal levels and how much is too much?
Okay, well, and I will not specifically say, because I am not a dietitian yet, so I can give you recommendations on where to go and things like that. But what I would say is talking with your physicians about that. I know a lot of multidisciplinary clinics are prescribing vitamin D for bone health specifically. And that was one of the things that we talk about, is making sure that we're getting optimal calcium levels as well. And I will talk a little bit more on the food side, and I don't know if this is normal for most people in clinic, but it seems like our boys don't really like milk. Nobody likes to drink milk anymore. So really trying to focus on getting that calcium with that vitamin D level.
Great. Thanks so much. Yeah, I think that having that dietitian as part of that multidisciplinary team is so important, because they can work with you and your child, or you as an adult with Duchenne or Becker specifically and directly, and figure out what your body needs, where you are, where you need to make adjustments. Kent, would you add anything to that? You're muted.
There we go. Sorry about that. I was actually looking up the dosing because we use it a lot. Kind of 2,000 units daily for vitamin D is kind of what people a lot of times will kind of give if you are low in vitamin D, or you can give, sometimes they'll do like 50,000 units a week for that for a while. And then, as we said earlier, you really need to think about trying to get the calcium in also along with it. Sometimes we'll prescribe tablets of, of the over-the-counter Maalox or Tums or things like that. They'll have calcium in it to go along with it also.
Awesome.
And I'll chime in really quick too. Thank you for mentioning the Tums and things like that. There are a lot of chewable forms of calcium, so you don't have to take the big calcium tablets that are kind of horse pills. So look around for gummy forms, liquid form, that kind of stuff that are going to be a little bit easier to swallow.
Absolutely. Absolutely. All right. It looks like we've got time for maybe one last question. This will be a question for Kiera. So the viewer said, I've seen some boys that tend to have large tongues. Does that impact their swallowing function? And is there anything that we can do to prevent that?
I do see that as well clinically, that some individuals seem to have kind of a larger tongue in Duchenne. And I don't know that there's any study specifically documenting that impacts that swallow function. I kind of step back and alongside the dietitian sort of look at how has weight been. Have we been stable? And that tells us, or going up and staying on the growth curve, and that tells us, are we getting enough calories in? And then and I also look at, can we keep it in the mouth? I see a lot of individuals that maybe the food is coming out of the mouth because the tongue is maybe a little bit big. And so maybe we work with some individual strategies with that person as well from there.
Comes down to individualized care. It seems like that's just the theme, which isn't a surprise, right? Every single person with Duchenne is different and unique and has different needs. And we can look at natural history and what we know about progression, but every single guy has his own unique story. Every single girl has her own unique story. And that's why that coordinated, comprehensive, multidisciplinary care is just so, so important. Well, thank you, Dr. Fawcett, Dr. Williams, Kiera. This has been a fantastic conversation. I know I personally learned a lot, and I'm sure that everybody at home learned a lot too.